Hello, and welcome to Health Centers on the Frontlines, the podcast of the National Association of Community Health Centers. We have a very special episode for you today, and I'm excited for you to hear it. I'm Ben Money, NACHC Senior Vice President for Population Health. And joining us today is Professor Emeritus of Public Health at the University of North Carolina at Chapel Hill and a legend in the health center movement, Dr. John Hatch. Dr. Hatch was instrumental in establishing the nation's first community health center in Mound Bayou, Mississippi, which at the time was an all African-American town where he pioneered approaches to addressing social drivers of health. Dr. Hatch went on to become a nationally known public health leader and pillar of our movement. So let's get started. Welcome, Dr. Hatch.
Thank you.
Several years ago, at one of the early Faith and Health lectures that's named in your honor, I was speaking on the topic of health centers screening for social determinants of health. Always my teacher and public health professor, you kindly corrected my terminology, stating that these were drivers, not determinants. The field is now moving away from the term determinants and now calling them social drivers or even structural drivers of health. Why do these terms matter?
I think they welcome a different level of conversation, that expectations within professions have moved forward at a pace that enables communities to play roles that really weren't believed possible by many people 50 years ago.
So when you organized and helped to organize the Mound Bayou, Mississippi community to establish the first health center.
It wasn't the first, Ben, it was the second.
Okay, the second. Okay. I know that's a little bit of a debate that goes back and forth. So thank you so much for clarifying that. Now the record is set that it was the second community health center. And I want to just ask you, what were those social drivers of health that you identified and how did you address them?
Well, at Tufts University, the two people who most enabled the effort at Columbia Point of public housing, it is where the first center was, brought together anthropologists, sociologists, social workers, people from the community. So the conversation sort of started at a different level. But one thing I would like to interject here is that Jack Geiger had been preparing, I guess, 4 or 5 years with the hope that he would be able to practice community health at a global level. And he was thinking about healthcare in Africa and other less developed nations. And at the same time, civil rights movement was attracting a lot of young people from the North, especially, to participate with Black people in the call for freedom. And Jack Geiger, Count Gibson, other physicians from up north volunteered to go south to just sort of evaluate what's going on with these young people. And some were in distress, and some were beaten, some were killed, Black and white together. It was the first time we'd seen anything like that in the South, excluding perhaps a civil war that wasn't all successful in bringing about the pattern of justice that many Black people had hoped for. But I guess overall, where Jack Geiger and Count Gibson were coming from was to begin to place the United States among the nations suffering great disparity in health status. And what should we hope for? Well, at that time, the the nation was saying we should give everybody a checkbook to go to see the doctor. Well, these men were at a point where they say, no, it's not just money. It's also what say would people have in the structure and organization of the healthcare system? Would they respond to issues that we see as important? And out of that grew the notion that citizen participation should be a part of the not only the health movement, but the entire what we called at that time the war against poverty. I guess what was that Johnson administration? Yeah. So we started in Boston, and my job was to sort of coordinate the survey process in several southern states because we didn't know exactly where it would be possible. There were political issues and a reaction from physicians in Mississippi, both black and white, saying that it's going to cut our practice. Black people welcomed the service, black docs, but said, but how are we going to eat? It's already not much out there. Those were kind of the realities as we began the process. And certainly Dorothy Farabee, Matthew Walker from Meharry were vastly influential in helping us to think about what a healthcare team in Mississippi might look like, who they could talk to. There was a lot of rhetoric around citizen participation, but nobody quite knew what that meant. I mean, we're really going to let people who can't read and write sit up and make decisions about healthcare? Eventually, the answer was yes. And we put together over time and with mistakes, groups of people who certainly enhance the targeting and appropriateness of things that we did. Uh, Another way to have looked at it, it was very closely akin to theories I read about in economic development process, where tasks were viewed from the perspective of what part of this could we develop local talent? How much education do you really need to be a nursing assistant? And how could we get professional organizations and societies to respect the new kinds of professionals that we propose to develop? Community outreach workers, nursing assistants, community health workers. Part of my job also was to discuss options and perspectives, hopes and dreams, and encourage local people to participate because initially, the response was, are you crazy? Are you going to really turn this over to, a group of people who might struggle with language and expression, and they would really do important things? And of course, the answer was, yeah. And there were talented people some of whom were not literate. Anita and I were discussing a man in environmental engineering. I think we also were the first health center to have an environmental engineer who incidentally trained about 25 environmental engineers in Mississippi with the help of Tufts University, University of Cincinnati, Dayton, and other established training grounds for sanitarians. Sanitary Society approved the program. The people who became engineers had to spend 6 months or a year in one of the schools that were co-sponsors of the environmental engineering. But it had profound effect on the community. Yes, we manufactured outhouses and put screens on windows and brought in new concepts of eating and what was healthy. So we were really trying to, I think, rather well, the opportunities that would be possible in the community health center movement. Some people went on to become technically able, some became licensed technicians and so forth. But the real story is in the hopes and dreams of their children and grandchildren.
And Dr. Hatch, what were the things that you saw in your assessment of the community that indicated to you that the health center really needed to move in the area of environmental health and focus on things that were outside of the clinic setting rather than simply treating patients?
Indeed. I guess it's fair to say that among the highest infant mortality rates in the nation would be found in the Mississippi Delta, which was the location of many large plantations occupied by people who had not been able to make it north yet. But the process was going, so we had a lot of elderly people for the first time living alone prior to the decline in cotton production. Black people were very welcome, but as that began to happen, the pace of migration increased. And often people with very little preparation for urban living found themselves in Boston, New York, Chicago, Detroit, including some of my relatives, I might say. But the conditions were as dire as they were likely to be in this country. Shacks, poor sanitation, insufficient amounts of food, low levels of education, and not a whole lot of hope in the poor community. When we arrived on site in Mississippi in 1965 or so, the average income of a very competent cook house cleaner was $15 a week. And those who were employed considered themselves fortunate. These were counties with predominant Black population.
I wanted to pick up on what you were just talking about in terms of just the abject poverty that you saw in that service area. There was widespread widespread malnutrition, for one understand, in that region. And you initiated and directed the North Boulevard County Farm Cooperative. Yes. And it served as kind of an adjunct of the Delta Health Center.
Yes.
You feel like that was the right approach?
Yes. It had been, well, what started some of this process was OEO had called Geiger to account when he sent in a big bill for staples, meat, bread, canned goods, et cetera, et cetera. Said, now, what's going on? It looks like you're running a chain store on the government. And Geiger said, well, if people are hungry, the specific medically is to feed them. And they were tolerant. They were good people, but nobody had ever passed out groceries at a health facility to our knowledge, but I'm sure it had happened before.
Well, in many states right now with Medicaid programs, including North Carolina, there's provisions in place to allow Medicaid dollars to actually cover um, non-medical related things like food and housing supports and transportation that impact the person's ability to maintain their health. And at NACHC, we're supporting health centers that doing more than just screening for social drivers of health.
I
Uh,
sure hope so, because
yeah,
in rural Mississippi, it was common for shacks not to be generating um, much rent. Like rent is $4 a month or maybe less. At the same time, there was very little maintenance once the owners didn't have vested economic interest. So steps were missing from shacks where there was a pregnant woman. That didn't make a lot of sense either, because there were injuries just as there were mosquitoes. So putting screen windows to the shacks might look like, well, what are you doing? But it very well could preserve the life of the mother and child. And I think the health center probably did go mostly toward mothers and children and health of the family. And I think perhaps rightly so, but the needs of elderly people were sometimes alarming, because families had sustained life in whatever ways they had to, including fishing, hunting, and even hunting, which was a staple when I was living in the country. We didn't hunt just for fun. We hunted for meat. We hunted for nuts and vegetables. And the same was true in rural Mississippi, especially when you cross over the levee and go in the land out there where they were closer to the water. There were berries, nuts, fruits. Most people my age knew how to go around and collect edible things that grow. Uh, Dandelions, flower leaves, so forth. And I learned that from a grandmother who had been born in 1852 and had lived through the slave experience. Most people my age, right now it's 94, have had those kinds of experiences with people whose journey has not always been secure.
and when you were developing the North Boulevard Community Farm Cooperative and really thinking about those efforts at addressing social drivers of health, 50 years ago, could you have envisioned what health centers could become? Um, is this what you had in mind? Because right now we got health centers that are establishing grocery stores, farm co-ops, transportation systems, and even affordable housing projects. I was in Denver, Colorado, and there's a health center that's building 150 units of affordable housing on top of their new facility.
Well, Ben, it's the first time I've heard this, and I'm just overjoyed that it's going on. But yes, indeed, my concern was that bringing in truckloads of food from Minnesota and Illinois to people who had spent a lifetime growing stuff was kind of insulting. What they lacked was the money to plant and land to plant it in. They had the know-how. So certainly African American people in the rural South had to have survival skills in order to stay alive and to hope to prosper. And by November, my family had enough food to eat for the next 2 years in a shed behind the house. Uh, Urban situations, different, but ingenuity there as well. At Columbia Point was the public housing unit placed the first health center in, and there were women at Columbia Point who went to the big market in Boston, bought food, canned it, and put it under the bed. Uh,
Yeah, that ingenuity of people is amazing. And one of the things that we're seeing now, you talked about sort of the decline in natural areas in the South and access to places where you can hunt and find fish. You know, so much of that has been impacted by environmental degradation that has occurred. And communities of color and the poor have historically been relegated to live in red line districts that have been now termed as sacrifice zones, where toxic waste dumps, polluting highways, chemical plants emitting air and water pollution are cited. The health impacts of these conditions are profound, from lead contaminated water creating developmental delays in children to cancer and respiratory conditions. You'd mentioned the environmental health engineers that you had at Mound Bayou. How do you think that legacy could be continued today, given all the challenges that health center patients and their communities are experiencing?
okay, first we know it's got to be a political process. Um, Communities in most cities where they have interstate highways are located in minority communities. In Boston, the path from airplanes leaving Logan Airport were over the predominantly Black part of Boston. It's deliberate planning. More sophisticated people can anticipate and make scientific input into a process that would lead to change. It also enables me to mention the name of an old friend, Ted Parrish. I think you knew Ted. Ted Parrish was a youth worker, community organizer in the South End of Boston. And some interests had seen fit to revitalize the South End and turn it into the most elegant community in the city. The housing design was lovely, well done. The houses were still stable after 150 years. And all you needed were people with money to come in and really add tone to the presence. And then Ted Parrish started sit-ins and took over a number of houses, and the city had a crisis on its hand with several hundred people arrested. He continued this process until there was negotiation that enabled the creation of, I guess, 100 odd apartment units that would be available to people of modest income. It's disruptive, it's dangerous, and sometimes heartbreaking to observe the confrontation between police who who were simply enforcers uh, and people who see their future disappearing. But in Boston, I think they dealt with it eventually in a fairly effective manner. Ted received the next year the Outstanding Social Worker Award in that city. Uh, there was conflict. People were jailed, and in other locations, I could imagine them being shut down for impeding the economic development of the city, would be one way to describe it. Uh,
I mean, one of the things you point out is the fact that change doesn't happen without some measure of conflict. Um, and I think that's really important. Community health centers, or the origins of community health centers, really emanated out of public health and public health approaches that looked at whole communities and community conditions, not just, within the four walls and confines of a clinical setting.
yeah, and what they did also was to bring in social science and statistics as a part of measuring impact of the healthcare intervention. And I think now not many people would advocate just putting more dollars in the pocket alone as an appropriate healthcare intervention. I think we've learned from those experiences, realizing that just paying the doctor won't do it because it won't change the poor housing or the political climate of the community. And I think so far we haven't found a substitute to participation. And, all throughout this movement, and people from the community have made the difference. In China, they were village elders. They were not educated people. Same thing in Mississippi. Now, the older folk went to school to qualify for the jobs available at that time. Their children have gone further. When we went to Mississippi, I think there were fewer than 20 Black physicians in the whole state. And through the Delta Health Center and its knowledge of pathways and the recruiting that went on to other medical schools, will you accept our people? Tufts University did some things that would be controversial today, like recruiting a science major who's teaching in Mississippi to go to medical school and giving them 2 years, no, what was it, 4 years to do the first two under normal tutelage. Now that's politically very sticky and difficult, but they did it. So there is a record of people who finished Mississippi schools, were allowed 4 years to get through the first two, and then they could fly. And it resulted in a profound change in the pool of African American people from Mississippi who were able to get medical, nursing, environmental training. Some of the storybook stuff, like the gentleman who was chairman of the board at Mound Bayou when I was last there, had completed his career in California, said he had finished his master's in environmental engineering and then got to go to APHA. And the director of a health center in California said, hey, look, we could use an environmental engineer. Would you consider it? He said he really didn't consider it, but the guy offered him a ticket to fly from Mississippi to California for 2 weeks to look around. And he took it. And they said, then they offered me more money than I ever thought I'd make in my life. So I left Mississippi. Well, there are a number of stories like that where maybe they didn't go back, but they entered a new world with a sensitivity that many people who had not seen poverty would not recognize.
Mm-hmm. And it's that lived experience, in addition to the sensitivity, really helps inform the projects and the initiatives they undertake and their ability to relate with the communities they serve.
Yeah, well, I think the community health center has probably enabled more African American, Hispanic, other poor populations, including Appalachia, to reach levels of employment that was traditionally out of reach. Some programs were modified, and then there was an analysis of ability to perform. One of the more unique cases was a man in Mississippi who was not literate, but he was one of the brightest people I've ever met. The master's degree trained director of engineering, environmental engineering in Mississippi was a man named Andy James. And Andy hired this guy because of a quick mind and willing worker and all of that. And one day, Andy was trying to put together some kind of machine. This guy walked in and said, "What's that?" And they said, "Well, it's how to put in, how to put this thing together." I said, "But it's driving me nuts." This illiterate man picked it up and said, "Well, I think this goes here and that goes there." And he followed the diagram and put the thing together. And the director of the program was dumbfounded. This man is not literate, but he put the thing together. And he went on to become a part of the research team, testing wells, knowing how to go and adjust the microscope that looked like clean water drawn from a local well, but it had all this stuff crawling in it. And he said, "There's bacteria, those are germs." And I remember seeing 50 people standing in line to look through a microscope in Simons, Mississippi, and marveling at this thing that could look at clear water and find bugs in it. That was a profound experience for me. And I wonder to this day if one of us who had college education had been conducting the education session, would people have gotten a message? I don't know. But they kind of knew that Nelson was smart, but he couldn't read and write because his folks had prioritized, picking cotton.
Mm-hmm. They had to just to survive. And he didn't have the benefit of a foundational education, but yet he was a very intelligent and capable man. Yeah. And, so what I hear you saying is, in terms of health equity or equity, racial equity, health centers kind of have two approaches. They've got the approach of the work we do out in our communities to address particularly health disparities, but then the work we do inside our health center to grow our own, develop our own staff, and invest in the people that work with us. But I tell you, community health workers are impressive in their own right. I tell you, with the COVID pandemic, and when I was at public health, we couldn't have made the kind of headway we did in terms of getting out personal protective equipment and health messaging, getting folks tested and eventually vaccinated without the community health workers. And I'll never forget the time that I joined you. It was probably back in it's going to be 89 or 90 we went to St. Helena's Island to the Penn School for a North and South Carolina lay health advisor training that you facilitated. That was one of the most memorable and impactful experiences that I've had in my public health career. So I just want to again thank you for that opportunity you provided to me. Gosh, over 30 years ago.
Well, that's one of my favorite places. I served on the board at Penn Center for some years, and it was a joy for me to interact with the people. As you know, most of them are direct descendants of a West African population that came to America to grow rice. And they had stayed around the Hilton Head area from the time of slavery up until the present time, and had worked out an agreement with the slave owners that they wouldn't try to run away if the slave owners allowed them to practice their faith and their family traditions. Africans tended to believe that distance in relationships for marriage was what you tried to encourage. And the settlers were slave owners, believed that close marriage to protect the money might be the way to go. But there coexisted under some tension what has been described as an independent Black or African cultural system coexisting with a slave society in the South. And I've had the great pleasure of having African students for summer programs at Chapel Hill. And when it's possible, I try to help them to find predominantly African communities in this country. And, that have survived sometimes 200 and 300 years, of exposure to slavery, but still maintain pieces of language and lots of the practices brought over from Africa. And there's been a lot of work by anthropologists and others in ways that these populations have interacted and what's left of the African tradition. I guess I was involved on the board for maybe 15 years.
Mm-hmm. Very much so. I actually am in touch with the new CEO of the Beaufort Jasper Comprehensive Health Center in that area, and she sent me some archival footage from their local PBS channel on the well drilling that they did back in the late 70s. Because as you know, the pediatricians at that health center would see a lot of children that had intestinal worms, and they treat the worms, and children would come back and they treat the worms and over, and then they realized that it was water. They did water testing, found that the wells were mixing with the septic systems, septic systems, and they needed to drill wells lower. There wasn't that capability within the county or the willingness to make that capability for those poor Black communities. So the health center actually bought well drilling equipment and drilled those wells and addressed the issue of intestinal worms.
Yeah, and we did the same thing in rural Mississippi. Drilled wells, built out houses, and taught people in the community how to do those things.
Mm-hmm. Yeah. And, it's the challenges in many respects that health centers see today are similar, but yet they're different. And I think in many instances, they're even more complex. But it really is through your foundational work, and health centers living out that legacy and seeing their services beyond just the four walls of clinical care and extending out into the community, that health centers are really making that difference and sit in that space between public health and primary medical care. So,
I'd like to ask you a question.
yes, sir.
I think rural populations in the South found strength and structure. And as you know, a lot of the work I've done in North Carolina was focused on churches, as was the case in Mississippi. And with urbanization, it's less clear to me that the traditional cultural systems that have enabled cooperation in the rural South or in southern cities exist in northern communities. For example, like Boston, which in 1925 held about 7,000 Black people, period, and now with a Black population of 250,000, mixed population, West Indian, Canadian, Black, Hispanic, so forth. Do you see entry points for development through prior institutional development? I guess would be my question.
I do, but I think it's even more varied now because now you have the advent of these virtual communities, these online communities, which for a lot of younger people have the same sense of community as do some of the physical, social, and societal groups that have traditionally been in place. Groups like the fraternities and sororities, social clubs, bowling clubs, even. You know, you see less of that and more uh, variety and modes of gathering than you have in the past. I even see that has changed as a result of the pandemic. That during the pandemic, out of necessity, there were a lot of churches that went from face to face to virtual. And now coming out of the pandemic, and you know, we're still in this wave, uh, churches have gone back to face, but then they're also doing virtual. So I know, for example, with my church, we have people that join that at one point had lived, you know, in North Carolina, but are now living in other parts of the country. But because they have a virtual service, they join in. But it's a different type of engagement when you're joining online and when you are face to face and in person. And I think one of the questions that's yet to be determined is what's the level of community cohesion and sense of mutual concern and accountability that we'll see when these virtual communities become more the norm.
Yeah, it's a challenge, and I recognize the continuing change in the decline of rural populations and a struggle for adaptation. I see it in my own family, and I guess the network of cousins would, from one grandpa, would be a couple of thousand people. So family still has currency, and certainly from my family, it was the church that was the place to go to prepare for change and upward mobility. It was a place in North Carolina where Southern blacks and white groups like the Quakers could come together and do things. I'm just less aware of the turbulence in this present environment, and I think the nation is going through a period of reassessments that's sort of disorienting to me.
To me as well. To me as well. It's actually fairly frightening. Yeah. And, those institutions in rural areas and urban areas that have been the glue, are they still that fabric of our society? And one of the things that we want to assure at NAC is that, community health centers will be there to be those foundational, patient-governed community institutions that can help to achieve health equity and social mobility for the people that we serve. And so, Dr. Hatch, I just want to thank you so much for the opportunity to sit down and chat with you. I missed that we're not face to face. I look forward to seeing you in December in Winston-Salem. But I just want to say thank you. Thank you for your leadership. Thank you for your wisdom and guidance, and your just sense of the arc of history and how this movement has really been tied to the civil rights movement. And you just always have a clear and present sense of where we need to go and what we need to do. So thank you, Dr. Hatch, for your time.
Well, thank you so much.
Produced by Heartcast Media.